Now, switching gears to the newer targets and the ADCs, the latest and the greatest we have. We've all heard about Pembro, and at ESMO they talked about that Nectin-4 or PD-L1 doesn't really matter. Does that really change your practice? Were you ever considering, should I check for Nectin-4, or was that information just reassuring for you that no matter what patient will benefit from Pembro most likely?
I think what we saw with Dr. Pal's presenting those updates from EV-302 was that regardless of Nectin-4 expression, patients benefit from Pembro. So I don't think it changes anything. I think it will be interesting to see in variant histologies, maybe like plasmacytoid that maybe theoretically have a higher Nectin-4 expression, whether there's a benefit in variant histologies to be giving Pembro. I think we don't have that much data in that space. I know there's retrospective studies looking at that. PD-L1 does not impact what I do really, both in the perioperative space and in the metastatic space at this time. I know we're going to be talking about some other targets that are changing maybe what we're doing, but at that point, those two are not.
Yeah, so talking about, the newer targets like HER2, we've seen like a new wave of drugs in the HER2 space. Historically, really, Herceptin and other drugs didn't really pan out in bladder cancer, but talking about the pan-tumor destiny trial, which showed impressive activity with the TDXD, do you want to comment on what your thoughts are? When are you checking for the HER2 status? I mean, I'll stick to you guys in the US because I know, Kala, you don't have that available in Canada yet. So what is your pathway for HER2 testing? How do you do that? And when are you incorporating it? Is it after EV or Pembro, or if they have HER2, do you want to give that to them before EV?
Yeah, so for now, we've gotten our pathology groups to do HER2 on every urothelial cancer, and I think they're doing it now in almost all solid tumor malignancies because of this pan-tumor approval. That is going to disseminate over the next 6 to 12 months, where basically you're getting your path. If it's lung, you're getting your lung moleculars, you're getting your HER2. If it's whatever, you're getting whatever that tumor type of interest is, plus HER2. So that'll be out there. And everyone knows this drug in community oncology because, unlike me, who's a specialist, everyone else is seeing a lot of breast cancer, right? So they know HER2, they like HER2, and they like the drugs that are associated with it. So I don't think uptake will be a problem. It's just going to take 6 to 12 months. And then the question is, well, where do we sequence it? And to me, right now, if I have a patient in clinic, it's probably, if they're not FGFR positive, a second-line agent after Pembro. But we don't really know where to sequence it.
Right, and I think the testing has some nuances, right? It's based on the gastric cancer testing, so that needs to be clarified to our pathologist. So let's say if somebody has FGFR alteration and HER2 alteration, so what would you choose, erdafitinib or TDXD?
It's a great question. You're looking right at me. It's the hardest question. Look, we have really high quality evidence for FGFR inhibition, so I think I would lean in that direction. The evidence for the HER2 therapy is very promising. It's a pan-tumor approval, but because the FGFR is a urothelial-based approval, I might lean in that direction. We don't see that many FGFR patients in the lower tract metastatic, right? All these data sets, in my practice, I think it's 10 to 15%. So there's, and we don't know as much about overlap and things like that in the truly metastatic setting. So for now, I probably would lean on the FGFR. Of course, if they're cis eligible for a doublet, I might go in that direction as well, but most of these patients after Pembro aren't gonna get cis-gem. I have 2 patients who have, but it's the minority. So I think probably FGFR followed by HER2, but I would love to see data because it's not like the toxicity of erdafitinib is well tolerated, even though it's oral. There's all sorts of toxicity associated with that therapy, and it's almost sometimes easier to give an ADC in clinic after a patient's already been on a prior ADC, they know what to expect. So we'll just see how it all shakes out over the next 2 years.
Yeah, and also I think it's good to have those options. Like, we don't know what the sequence would be, but if a patient gets these drugs throughout their journey, we'll learn. Anything you want to add?
Yeah, I think there's nuances to the HER2 testing also. I think I agree, first off, we have to have pathology be doing the immunohistochemistry for patients with bladder cancer, which wasn't our prior standard. And then, we've been sending next generation sequencing for patients with metastatic bladder cancer for a while now since we've had FGFR. But the approval for TDXD is based on HER2 3+, and then we're seeing these other trials at ESMO where the definitions are different in terms of the HER2 positivity, both including HER2 3+, 2+ with FISH positive, and also the HER2 low with 1 or 2+ and a FISH negative. So I think there are nuances. We have this approval just for 3+ right now. I think I probably would agree, maybe I would lean towards FGFR. Also, it offers an oral option to patients that want to maybe take a break from infusions.
I think in the data we saw even 2+ benefit, but again, it's all about what options the patient has and whether you'd be willing to do it for 2+ or not. And then we saw another data presented at ESMO. Kala, your thoughts on the DV and Pembro. Granted, the numbers were small, but preliminary evidence for our audience, DV is the dasatinib, vedotin, another promising ADC in the HER2 positive urothelial tumors.
Yeah, I think based on what we've seen from EV Pembro, which really has the same chemotherapy MMAE backbone, and its ability to combine very favorably with the immune checkpoint inhibitor, I think seeing a similar sort of outcome, similar response rates up in that 60-70% with DV perhaps is not so surprising to me. I feel there's something about MMAE's ability to combine with the immune checkpoint inhibitors that is maybe a little different than the other ADCs. Time will tell, of course. So I'm excited about this. I think, though, we'll face challenges because of the phase 3 trials are using platinum-based chemotherapy as a comparator arm, and we in Canada just got Health Canada approval for EV Pembro. So it becomes a difficult discussion with patients to say, well, we have a trial of DV versus platinum-based chemotherapy where they could get platinum-based chemotherapy, or you could get EV Pembro, which right now is sort of rising to the top in terms of response rates, PFS and OS. So I think the development path for DV could be challenging. The drug itself looks very exciting. And I think it starts to raise questions about how we sequence these drugs going forwards.
Yeah, I think, again, doing the phase 3 trial is the big, this cohort had 20 patients or so, and the whole challenge of the changing standard and how we can really run these trials will be important.
I think, the other challenge with this is the embarrassment of riches with vedotin, because I agree with you, there's something magical there with MMAE and checkpoint inhibition, because we have 2 early studies, one late, I guess now one early, with vedotin checkpoint inhibitors with a percentage response rate around 70%, right? We can quibble over the details. Then you have SG immunotherapy, sacituzumab govitecan, which does not have MMAE, and you have some other ADCs with immunotherapy that looks like 30, right? 35% response rate. So there's something there. It could be the molecule, right? But it could be also the synergy. I think the problem is we are developing this drug in the front line, which serves 2 issues. One, it's probably going to be positive, and that's going to be great for patients. But then how do we decide what to give? One has a blanket approval. One I have to wait on HER2 testing, right? So that is going to be a challenge unless the data looks outstanding. There's a high bar to clear for that, right? So the next problem is, well, then what about the sequence, which is the data we really need to see. Can you give vedotin after vedotin, right, if it's a different target? So obviously, we're going to get that data set as well, but it's going to be less robust. It won't be the same size, and we'll just have to kind of figure out that step as well. Yeah.
Yeah, and with having the same payload, is the neuropathy going to be an issue? TDXD has a different payload, so does that make more sense in the subsequent line therapies?
Yeah.
It's an important question.
I think it's a lot about the toxicity profiles, and the sequencing will really be a key question.